Good day, fellow learners. This is your mentor, Gapuz, your fact check buddy, joining you for this whole new format of a video that we're uploading today. And this contains the trends on the next generation NCLEX-RN for this month. So I would love to see you give us your feedback, comment on the comment section below, and tell us how this video that we have carefully crafted and we have collated all the concepts that we think you should remember before you take your test should help you out. So before you take your test, make sure that this should be the last video that you have to watch before the month ends. And we're going to do this regularly based on your feedback. So give us a thumbs up sign, and we would appreciate if you can drop a few comments, both positive and negative, to help us continually come up with videos that serves your need. So stay put, listen intently, and answer the questions with me as we engage in this teaching and learning session. Let's do this. On to our case number 45. And this is known as Menkes syndrome or Menkes disease. Now, what should be the first thing that comes to your mind related to this disease or syndrome? Remember, this is about deficiency in copper in the body. To contrast it with your Wilson's disease, your Wilson's disease is about accumulation or having an excess amount of copper in the body. Both are genetically transmitted. The difference is Menkes syndrome or Menkes disease is X-linked recessive, whereas your Wilson's disease is autosomal recessive. What does that mean? Menkes syndrome, being X-linked recessive, is transmitted by the mother to the son. So it's most common among boys. Whereas your Wilson syndrome, which is transmitted through autosomal recessive pattern, simply means that both parents must be trait carriers, so that there's a 25% chance of their would-be children to have the disease and 50% chance to become trait carriers. So the important thing they have to remember is that people with Menkes syndrome as well as Wilson syndrome needs to consult with a geneticist for them to understand how the disease is transmitted. Now, Menkes syndrome or Menkes disease is a rare genetic disorder. It's transmitted X-linked recessive genetic disorder with faulty copy of the ATP7A gene. And once again, to compare that to your Wilson's disease, in Wilson's disease, you have a faulty copy of the ATP7B gene, where the body has trouble absorbing and using copper, a mineral needed for brain and nerve health. Therefore, primarily, the brain gets affected in a client with Menkes disease or Menkes syndrome. So babies with this condition may have weak muscles. They are prone to seizures and problems with growth and development. And if you'd notice, take a look at the hair. It's kinky, sparse, or brittle hair that looks and feels different. So it mostly affects boys, and the symptoms usually start a few months after birth. It is caused by a gene problem passed down from the mother. That's why it's X-linked in terms of inheritance pattern. Is it life-threatening? It is. And early diagnosis is very important for the provision of the child's supportive care. Now, skin and hair abnormalities are the most striking signs in Menkes disease or Menkes syndrome. You'll see kinky, brittle, and depigmented hair. It's the most distinctive physical sign. And here, we have here on figure 1, the skin and the hair appearance of a patient with Menkes disease or Menkes syndrome. You have hypopigmented skin with short, sparse, coarse, lightly pigmented, and kinky hair. And if you're going to take a look at the hair underneath a microscope, you'll see trichorexis nodosa, or you will see nodes along the hair shaft that makes the hair brittle, and it's easily destroy. So that's one of the characteristics of MD or Menkes disease. So the outstanding features of Menkes syndrome or Menkes disease include your trichorexis nodosa, nutty weak hair that breaks easily, the absence of the blink reflex, which is due to a neurovisual impairment, and of course, normal reflexia. Although normal reflexia means normal reflexes, and you would think, how come? Because the brain is usually affected in Menkes syndrome or Menkes disease. It's because the normal reflex response usually occurs in the early stages of the illness. So remember, TAN, trichorexis nodosa, absent blink reflex, and normal reflexia. TAN, outstanding features of Menkes syndrome. Now, the diagnostic highlights of Menkes syndrome include, remember the code, the acrostic Menkes, missing copper, that's the letter M in the body, causes brain and nerve problems. E, early signs appear in babies, so this would include weak muscles, seizures, slow growth, not absorbing copper properly due to faulty gene, that's ATP7A, and then kinky brittle hair, which is an outstanding feature. And exam and genetic testing confirm the diagnosis. This could either be done through blood or saliva as your specimen, and then supportive care and early treatment can improve life quality. So you just have to know what the deficits are, and therefore you have to implement a set or a bundle of interventions to improve on the quality of life of the patient. Now, the main nursing priority, this is a functional concept for a child with Menkes syndrome, is to promote comfort and prevent complications through supportive care. And what does that entail? Now, due to the hypotonic muscles or weak muscles and the laxity of joints, these children are prone to injury like joint dislocation. Therefore, applying padding at the elbows, the knees, the ankles, the wrist, and the sides of the crib or wheelchair would definitely make some difference in terms of preventing decreasing the risk for injury. Now, what are the treatment modalities for Menkes syndrome? The treatment includes the following. So first and foremost, we need to monitor the child for seizures and breathing difficulty regularly, and the medications for these symptoms must be provided by the physician. We need to administer medications like anti-seizure drugs and copper histidine injections that we're going to discuss in detail in a little while. Nutrition support to careful feeding or tube feeding when needed because the child is prone to seizures. Assist with mobility, and definitely you need to pad their joints and provide physical therapy for weak muscles. Guide the family with education, emotional support, and home care tips, especially when they're the ones administering the medications to the child. And evaluate growth and development and report any decline or potential red flags for complications. Now, let's talk about the copper histidine treatment. The medicine appears blue in color. It is placed in a small sterile ampule like a tiny bottle with 250 milligrams in 0.5 ml administered twice a day. Now, the ampules are kept cold at 4 degrees centigrade and stored in light protective bags to keep the medicine stable. Now, these medications usually administered subcutaneously. Now, discharge instruction to the parents of a child with Menkes syndrome include how to clean the skin and safely inject the medicine. Remember, subcutaneously. Now, how do we use the concepts or the functional concepts which we learn? The way to deal with this type of case is to read through it and reflect on every single set of data that you'll need. Okay, so let's go over the history. The infant was born to non-consanguineous parents. History of generalized tonic seizure and nystagmus since age 1.5 months, currently on phenobarbital. So we have an anti-seizure medication. Referred at 4 months old with hypopigmented skin. There you go. Kinky hair. There you go. Subtle flexor spasms. There you go. That should give you a clue. And then we have here hair microscopy revealed. There you go, trichorexis nodosa, one of the outstanding features. Anthropometry indicates severe protein energy malnutrition, and definitely ophthalmological exam reveals brown iris, clear cornea, sharp disc, flat retina, Absence of blink reflex could be a red flag that you may want to consider at this point. And then you have the neurological findings. So the infant appears lethargic. So that could be due to weak or hypotonic muscles. And then, of course, the second finding, hypertonia of limbs and hypotonia of trunk. That should also give you a clue, okay? And then we have normoreflexia, okay? That would tell you that this could be in the early stage of illness. And then you have myoclonic seizures, responds to voice, maintains brief eye contact, unable to roll over. That could mean very weak muscles, okay? Okay. And then head lag present. Other systems, no remarkable findings. And the plan of care includes this: continuous seizure management, initiate nutritional support, monitor neurodevelopmental milestones, support diagnostic workup for suspected metabolic or genetic disorder, likely Menkes syndrome. Now you got the clue on the last word, and that's very typical of the NGN. Pay particular attention to this tip I'm going to tell you. Read from the first letter up to the last period. Who knows? You might get some clue. Okay, so since this is a genetically transmitted disorder, it's also important to know the history of the child. It says here that the infant was born to non-consanguineous parents. That means that the child was born from couples who are not biologically related. And that is a good thing to consider, because your Menkes syndrome or Menkes disease has a genetic basis. Okay, so now let's go through case number 45. A 4-month-old male infant with non-consanguineous, meaning non-biologically related parents, is referred for the clinic for further evaluation. He has a history of generalized tonic-clonic seizures and is diagnosed since 1.5 months of age, is currently on phenobarbital. On assessment, the infant presents with hypopigmented skin. There you go. That's outstanding. One of the outstanding features. Kinky hair, another one. Trichorexis nodosa, subtle flexor spasms, severe protein energy malnutrition, absent blink to light, limb hypertonia, truncal hypotonia, and head lag. Which of the following conditions most consistent with these findings? Shall we consider it Tay-Sachs disease, Menkes syndrome, Zellweger syndrome, or infantile spasm or West syndrome? As we discussed, this is clearly Menkes syndrome or Menkes disease. But the way to study this case is to go over the other options which are not related to the answer and try to reflect how come these are the options. Maybe the other conditions that are mentioned here, contained in the other options, have some similar signs and symptoms as that of a patient with Menkes syndrome or Menkes disease. Okay, so Tay-Sachs disease typically presents with hypotonia or developmental delay. This is also genetically transmitted, and the outstanding manifestations would be your cherry red spot on the retina, but there's no kinky hair or copper-related features. What you would notice in a child with Tay-Sachs disease is that they have overreactive motor reflex. Remember that motor reflex should disappear at 3 to 4 months, but for Tay-Sachs disease, it goes beyond that. So if you have a hyperactive response to startle reflex at 6 months, that could be a potential indicator that the child could be having Tay-Sachs disease. Once again, hypotonia is a feature of Tay-Sachs disease that's similar to Menkes disease or Menkes syndrome. Zellweger syndrome is a paroxysmal disorder that may cause hypotonia and seizures, but lacks the hair abnormalities and copper transport issues seen here. Now, paroxysmal, actually, these are like the cleanup enzymes in the body that gets rid of toxic substances or fats that were not metabolized properly. So when you have a paroxysmal disorder, you don't have that cleanup device. So in essence, toxic materials accumulate in the body leading to seizures. Okay, so hypotonia and seizures are present in Zellweger syndrome in the same way as these symptoms could also be manifested in Menkes syndrome or Menkes disease. However, the hair abnormalities are not present in Zellweger syndrome. So Zellweger-like facial appearance, you see in the picture, you have a large forehead, flat face, low muscle tone, and these are common in severe paroxysmal disorders. Okay, now, infantile spasms or West syndrome may present with seizures. Seizures also may occur in clients, specifically during the late stage of the disease, Menkes syndrome, okay, as well as your Tay-Sachs disease and developmental delay, but not the distinctive hair and metabolic features of Menkes syndrome. So once again, what differentiates infantile spasm is the absence of the distinctive hair and metabolic features of Menkes syndrome. So infantile spasm is a rare and severe form of epilepsy in infants and primarily caused by either structural abnormalities in the brain, genetic mutations, or metabolic disorders. So to summarize, the unique feature of Menkes syndrome or Menkes disease would be the kinky brittle hair due to copper deficiency. Pay particular attention to that. If you get to see that right away, think Menkes disease. And then for Tay-Sachs disease, you have your cherry red macula and exaggerated startle response or motor reflex that remains active beyond 3 to 4 months. And then Zellweger syndrome, we have craniofacial features, liver as well as kidney involvement. And your West syndrome, which is your infantile spasm with hips arrhythmia on EEG, and pay particular attention to the fact that in a patient with West syndrome, they would usually have seizures. And the most important thing that you have to remember about these seizures is the fact that it may also occur in clients with Menkes as well as your patients with Tay-Sachs disease. Okay, so what matters the most is you know how one of those diseases that were mentioned in the options differ from one another. Okay, now pay particular attention to the EEG pattern here. It says hips arrhythmia, which simply means that there is chaotic EEG pattern. Okay, so it reflects a very chaotic wave that could be related to strongly associated with infantile spasms. Okay, and that occurs with a rare form of a seizure disorder known as West syndrome, rare form of epilepsy. Our teaching and learning session for case number 46. And this is something I'd like you to remember. It's about Kernicterus, otherwise known as bilirubin encephalopathy or chronic bilirubin encephalopathy or neonatal bilirubin-induced neurologic dysfunction. As the term implies, you have two outstanding things that you have to focus on here. First, you have bilirubin. And second, you have encephalopathy, which gives you a clue that this is a condition in the brain that could potentially be associated with elevated bilirubin levels. First and foremost, what is the normal bilirubin level in the newborn? It depends on how long ago was the baby delivered. For those who are less than 24 hours, 6 milligrams per deciliter is usually considered normal. But for the sake of supporting your ability to memorize, you can just peg that the value at 5. And when the baby is 24 to 48 hours, peg that value to 10. And when the child is more than 72 hours, peg that value to 15. So in that case, you have 5, 10, and 15. So if the baby is more than 72 hours, a bilirubin level above 15 could be considered elevated. That's a good clue. So Kernicterus is a serious complication of RH incompatibility. So let's go back a bit down our memory lane. Let's extract from our minds about RH incompatibility. Now, this condition occurs when the mother, who is Rh negative, carries a child who is Rh positive, in which case what happens? Well, the mother forms antibodies against the Rh positive blood of the baby. Why is that so? Well, let's review a functional concept, which could be a word, a phrase, a sentence, or an entire paragraph that gives you a direction on how you should think to deconstruct a question. So the functional concept is an Rh positive blood of the mom can be mixed with both positive or negative blood. Okay. And if the mother has an Rh negative blood, can be mixed only with an Rh negative blood. So in Rh incompatibility, what happens is the mother is Rh negative. And what did we say a while back? Should only be mixed with an Rh negative blood. However, if the mom married someone who has an Rh positive blood, in 90% of the time, the Rh status of the father is carried by the fetus. So what happens now? The mother is Rh negative and the baby is Rh positive. And these types of blood are not compatible. So what happens? You have Rh incompatibility. But the first baby is actually safe. Why? Because the antibodies produced by the mother's Rh negative blood usually occurs from the time of the separation of the placenta from the uterus, because it is believed that during that time, there's going to be a mixture of the mother's and the baby's blood. Therefore, the mother's blood, which is not compatible with the baby's blood, will form antibodies. And these antibodies eventually would perceive any Rh positive blood in future pregnancies to be something that's not compatible. So in essence, the Rh incompatibility leads to red blood cell destruction, otherwise known as hemolysis. And when hemolysis occurs, bilirubin is released. But the increased unconjugated bilirubin overwhelms the immature liver of the baby. And so what results will be Kernicterus, or in simple terms, jaundice in the brain, okay, or jaundice of the brain, or elevated bilirubin levels affecting the brain function. So Kernicterus specifically refers to the irreversible or permanent brain damage caused by bilirubin toxicity. Bilirubin encephalopathy, on the other hand, is another term that describes the acute phase before permanent damage occurs. So what causes Kernicterus? It's due to excessive unconjugated bilirubin brought about by rapid red blood cells destruction, because the red blood cells of the mom and the fetus are not compatible. And this unconjugated bilirubin crosses the blood-brain barrier due to severe neonatal hyperbilirubinemia, which simply means you have an elevated bilirubin levels in the blood that's at more than 20 milligrams per deciliter. Said a while back, remember the 5-10-15 rule. Less than 24 hours, 5 milligrams and below should be normal. 24 to 48, 10 milligrams and below should be normal. And if the baby is 72 hours and above, 15 milligrams and below should be normal. So at 20 milligrams bilirubin levels, that would definitely cross the blood-brain barrier and may potentially affect brain functioning in the baby. So what are the outstanding features of Kernicterus? You have here Kernicterus first. K, coma-like lethargy. So there's going to be extreme drowsiness or unconsciousness. Now, this is difficult to recognize because we know for a fact that the neonate would usually spend 20 to 20 hours a day sleeping. So it's very important that an expert should assess the level of consciousness of the baby. And then exaggerated reflexes, including hypertonia or later spasticity, and then rigid body arcing or opistotonus, as you can see on the picture here. You have arcing of the back and signs and symptoms of central nervous system irritability, usually manifested by high pitch or shrill cry, and of course tremors. And then you have ineffective feeding or poor sucking or refusal to feed, as is described by the mother. And then seizures or convulsions could occur, coupled by twitching or tremors. And of course, there's the sunset eyes, in which there's a downward deviation of the eyeballs like that. Okay, that could also be present in hydrocephalus, which could definitely tell us that there is something wrong in the central nervous system. And then respiratory distress or irregular breathing and unusual posturing like decerebrate rigidity. This is actually a posturing in which there is rigid extension of the extremities, as you can see here on the picture. Okay, so it's either arcing of the back or rigid extension of the extremities. We have decerebrate or opistotonic positioning. And then sensory neural hearing loss, which could be noticeable after a couple of months or even years. So this could be a late sign of your kernicterus. So once again, you have kernicterus, beginning with a K, comma. I'm sure, never mind the spelling issue. What matters the most is you are reminded what kernicterus is all about. Okay. Now, what are the diagnostic highlights of kernicterus? You have definitely number one, serum bilirubin that's critically high, usually above 20 milligrams per deciliter in term infants. Imaging that shows the basal ganglia is affected. So meaning there could be changes. Now, in the basal ganglia, you have the part of the brain known as your globus pallidus. This is a part of the brain that's responsible for maintaining normal movement. That's the reason why there's abnormal posturing in the child with kernicterus, because the globus pallidus in the basal ganglia that is responsible for maintaining normal movement is affected. And then you have clinical signs of neurologic dysfunction, decreasing level of consciousness or lethargy, hypotonia, opistotonus, or in extreme cases, seizures. And then K, kernicterus risk factors that could be present. You have RH incompatibility, G6PD deficiency, which is also a blood disorder, and definitely prematurity. The most outstanding there is RH incompatibility. That occurs when the mom is RH negative and when the baby is RH positive. Now, the common complications of kernicterus includes permanent neurologic damage, such as cerebral palsy, sensory neural hearing loss, or developmental delay. Now, whenever the signs and symptoms that points out to kernicterus are present, the main nursing priority for a child with kernicterus is to implement immediate exchange transfusion. And the purpose of that is to rapidly lower the bilirubin levels and prevent further brain damage. Now, exchange transfusion involves the following. First, small amounts of the baby's blood are withdrawn and replaced gradually with the donor blood. It's usually done over a 1 to 2 hour period. And note that the volume exchange is typically double than the infant's blood volume. So for example, if the infant has a blood volume of 80 to 90 ml per kilogram, so you have to prepare double than the infant's blood volume. So 80 to 90, multiply that by 2 to double it. So it's going to be 160 to 180 ml per kilogram of body weight. And then it involves continuous monitoring of vital signs, glucose as well as electrolytes and calcium. And we need to watch for complications like a decreasing heart rate or bradycardia, decreasing sugar levels like hypoglycemia, and the occurrence of electrolyte imbalance, and definitely infection. That's why the temperature of the child must be carefully monitored. Now, the next question is, how much blood is withdrawn in exchange transfusion? So here's an example. So if the total blood volume of a newborn is approximately 80 to 90 ml per kilogram of body weight, Double the volume for exchange transfusion. So multiply 80 to 90 by 2. So you'll get 160 to 180 ml per kilogram. And that's what's being exchanged. So for a 3-kilogram newborn, all you have to do is to multiply the weight with 85 ml, which is the approximate blood volume, okay, per kilogram. So you multiply that by 3, you will get 255. However, if you're going to prepare for exchange transfusion, you have to double 255 ml. So if you multiply that by 2, you'll get 510 ml. That's the total that's being exchanged. And this is done in small aliquots. Aliquots meaning small portions of a total part, okay? So like for example, 5 ml per cycle in preterm infants and 10 ml per cycle in term infants. And this procedure is usually done in 1 to 2 hours. So here's case number 46. A 3-day-old full-term male infant presents to the emergency department with poor feeding, lethargy, and high-pitched cry. Those group of symptoms, otherwise known as syndromes, should tell you there's something wrong with the baby. The first thing that you would see that a baby is sick is that there's poor feeding or they're unable to feed. And then you have decreased level of consciousness, the baby becomes lethargic, and the characteristic shrill cry or high-pitched cry. We all have it here. First sentence. You're lucky if you'll find a question such as this. The mother reports the baby has been increasingly deeply sleepy and difficult to wake with noticeable yellowing of the skin and eyes. Now, this is a little tricky because if you talk about pathologic jaundice, it is jaundice that occurs less than 24 hours after the baby's delivery, which tells us that there has been red blood cell destruction or hemolysis from the time the baby is inside the uterus and it became obvious when the baby was born. However, do not focus on the age of the child in relation to the jaundice, but rather focus on the central nervous system group of symptoms like poor feeding, lethargy, and high-pitched cry. And then read further. On examination, the infant shows hypotonia, intermittent arcing of the back or opistotonus, and sun-setting eyes. Now, even if yellowing of the skin, the eyes could be considered as physiologic jaundice after the first 24 hours after birth, the fact that you have several symptoms that tells you there's potentially an affectation of the central nervous system, we cannot just solely rely on the fact that you have here a 3-day-old full-term newborn with yellowing of the skin and the eyes, because in normal circumstances, that could be misinterpreted as physiologic jaundice. However, the laboratory tests reveal a serum bilirubin level of 28 milligrams per deciliter. That's the clincher. If you know your normal bilirubin level. Once again, you have your 3-day-old full-term infant, which simply means our maximum value for the serum bilirubin level that could be considered as normal should be 15. However, you have almost double that value in this case, 28. So which simply means that there's elevated serum bilirubin. And by definition, kernicterus occurs when the serum bilirubin level, meaning the level of bilirubin in the blood, is more than 20 milligrams per deciliter. So let's answer the question. Which intervention should the nurse anticipate? Is it 1, administer oral iron supplementation? Now, number 1 is the intervention for iron deficiency anemia, which could also be present in babies who are overfed with milk, because milk is a poor source of iron, but that's not what the case contains at the moment. So 2, prepare the infant for exchange transfusion. We can consider it's one of those functional concepts we discussed a while back. 3, initiate intravenous antibiotic therapy. There's no presenting symptom that would tell us that the main problem is about an infection, okay? And 4, teach the mother how to properly latch during breastfeeding. It could be a concern if your baby is normally as it is. However, if the baby is manifesting several signs and symptoms that would point out to a potential abnormality, option 4 is definitely not the answer. So based on the functional concepts that we discussed, the best answer would be to prepare the infant for exchange transfusion. Okay? Before we begin, let me just highlight something. Since we're going to talk about emphysema, remember emphysema is also known as pink puffer. And just for you to remember it in an easy way, remember emphysema, it has a P. So pink puffer. Pink with a P, puffer with a P, emphysema. To compare that to your chronic bronchitis, which is also known as blue bloater. So for chronic bronchitis, remember bronchitis with a B, blue with a B, bloater with a B. Okay, now why is emphysema also known as pink puffer? Because despite the deficiency in oxygen, they're able to maintain a pinkish color of their skin. Why is that so? Because they have learned how to expel carbon dioxide by puffing or pursed lip breathing. That's the reason why they are not cyanotic initially on their presentation. So on to our case number 47, and we're going to talk about emphysema or pink puffer. Remember the P in emphysema, it's pink puffer. It's P, not Phi, okay? Pink puffer. So emphysema is a chronic obstructive pulmonary disease. It's part of the group of disorders collectively known as chronic obstructive pulmonary disease. So primarily, it's characterized by the destruction of alveolar walls, leading to reduced gas exchange and surface area. So the main problem here is that the alveoli become damaged. So how does that happen? Well, the common risk factor would be chronic exposure to irritants like smoking, environmental factors like dust, okay, occupational hazards like gas fumes. And then this could lead to persistent inflammation in the alveoli within the lungs. And then that leads to enzymatic breakdown of the alveolar walls that eventually lead to destruction of the alveoli, leading to severe hypoxia, meaning decreased oxygen, hypercapnia, retention of carbon dioxide, and this leads to respiratory acidosis, in which carbon dioxide is retained inside the lungs. Now, emphysema is most commonly caused by long-term exposure to cigarette smoke, air pollutants, or occupational irritants, and may also result from a genetic deficiency in alpha-1 antitrypsin. Alpha-1 antitrypsin has a special function of protecting the walls of the alveoli, and so therefore, it helps maintain its elasticity. So if you are deficient in alpha-1 antitrypsin, what results could be easy destruction of the alveoli and loss of lung elasticity. So emphysema causes progressive dyspnea, especially on exertion. So the main presenting symptom could be dyspnea on exertion, and there's going to be an increase in the anteroposterior diameter of the chest, that's also known as barrel-shaped chest, and then a resulting pursed lip breathing and minimal cough with scant sputum. So emphysema can potentially lead to respiratory failure, pulmonary hypertension, and right-sided heart failure, or cor pulmonale. Why is that so? Because of the increased pressure in the respiratory system, it will be harder for the right ventricle to push blood into the pulmonary arteries for oxygenation in the lungs. And just like any other muscular organ, the right ventricle, when it's pushed to the limit, it's working so hard, eventually it hypertrophies. And so right ventricular hypertrophy can potentially lead to right-sided heart failure, and that's what is termed as cor pulmonale. So it could be associated with the increase in the pressure within the pulmonary system. So management of emphysema includes priority would be smoking cessation, and then the use of bronchodilators, corticosteroids for long-term management, pulmonary rehabilitation, and in severe cases, oxygen therapy or lung volume reduction surgery. Now, what happens in lung volume reduction surgery? They remove the most damaged part of the lungs so that the healthy parts can be maximized in terms of functioning. So the unhealthy parts, therefore, are removed such that there would no longer be retention of carbon dioxide that could potentially lead to respiratory acidosis. So when you say lung volume reduction surgery, the part of the lungs that are destroyed by the disease are removed in order to maximize the functioning of the healthy parts. So what are the signs and features of emphysema? You have here the acrostic smoking, so shortness of breath on exertion, minimal cough with little or no sputum, O, overinflated chest or barrel-shaped appearance of the chest, or increase in the anterior-posterior diameter of the chest, keeps lips pursed while breathing. That's what we call pursed lip breathing, or puffing. That's why they're called pink puffers. Increased respiratory rate or tachypnea. So it's beyond 20 respiratory rate per minute. No cyanosis initially. That's why we have the pink puffer presentation. And of course, because of their need for more energy, because of their dyspnea, they would usually exhibit gradual weight loss due to energy spent on breathing. That's the reason why when a client has emphysema or COPD for that matter, they should be given high calorie and high protein snack. Okay, like you can serve them peanuts or peanut butter sandwich, because that will enable them to source out energy from their food intake. Okay, they need additional source of energy so that they don't lose weight. Now, drugs used in emphysema or COPD management includes the following. We have the acrostic, again, lungs, long-acting bronchodilators like salmeterol or tiotropium, and then use of antibiotics like amoxicillin, clavulanate, okay, and then nebulized beta agonists like albuterol. Your albuterol has the potential to cause palpitations. Remember, PIN, palpitations, insomnia, and nausea. So it's very important for the nurse that if the patient's taking albuterol, you need to monitor the heart rate. And of course, glucocorticoids could be inhaled or systemic to reduce inflammation. And if the glucocorticoid is given as an inhaler, it's very important to assess the patient for the potential of oral candidiasis if they are using a metered dose inhaler. Okay, so the presence of whitish deposits in the mouth should be referred to the physician. So as short-acting bronchodilators like ipratropium and albuterol for quick relief. So remember, LUNGs, long-acting bronchodilators, use of antibiotics, nebulized beta agonists, glucocorticoids, and short-acting bronchodilators. So before we proceed to use what we learned in terms of the functional concepts we discussed, let me introduce you to the world's oldest passer of next generation NCLEX, proudly mentored by me. We have Miss Flor Villarreal from Bicol region in the Philippines. Okay, so thank you for the trust, Madam Flor Villarreal, US RN. Okay, so she passed the test, was December 2, 2024. Now back to our functional concept. Now, functional concepts could actually take the form of a word, a phrase, a sentence, or even an entire paragraph that gives your mind a sense of direction on how you're supposed to deconstruct questions on the next generation NCLEX. So here's a functional concept. In acute respiratory distress from emphysema, fast-acting bronchodilators like albuterol are prioritized to rapidly open the airways. So the bronchodilators should be the priority to be administered to the client. With that in mind, let's answer a case. So Mr. John Ramirez, 68-year-old chronic smoker, arrives at the emergency room with severe shortness of breath, audible wheezing that may potentially indicate narrowed airways, and use of accessory muscles during breathing. He has a history of emphysema and reports running out of his maintenance inhalers 2 days ago. His oxygen saturation is 88% on room air. We know for a fact that the normal oxygen saturation on room air should be 95 and above. So this is 88, it's below 90. So this is within the critical range of 85 to 90, okay? And he is visibly anxious. Based on the United States clinical guidelines, which medication should the nurse anticipate administering first? Now, if you are given this type of question, you would notice that all the drugs that are mentioned in the options, like 1, oral prednisone, 2, long-acting beta-agonist, 3, inhaled corticosteroid, and 4, short-acting beta-agonist by nebulizer, all of these are appropriate drugs for a patient with emphysema. However, the question is asking, which should the nurse anticipate to be administered first? So among this group of drugs, which one do we anticipate to be given first? What did we say a while back? Using our functional concept, in acute respiratory distress from emphysema, fast-acting bronchodilators like albuterol are prioritized to rapidly open the airways. So since the client could be having difficulty breathing, the priority therefore, the answer is number 4, short-acting beta-agonist via nebulizer, like your albuterol. Now on to our case number 48. We're going to talk about depression and Parkinson's disease. A lot of people are asking, which comes first? Is it depression or Parkinson's disease, or the other way around? Parkinson's disease before depression? Well, the answer to that question is both. Sometimes depression could be the initial manifestation of Parkinson's disease, and sometimes in some other patients, Parkinson's disease develops first, and then since the condition is chronic, eventually depression results, okay? So whether it occurs before or after, depression occurs with Parkinson's disease. That's our first functional concept. Here we go. So when we speak of functional concepts, it could be a word, a sentence, a phrase, or even an entire paragraph that gives your mind a set of rules that you can use when you deconstruct the question, okay? In essence, a functional concept is both a content and a test strategy. So let's begin with our first functional concept. Parkinson's disease involves degeneration of dopamine-producing neurons in the substantia nigra, that's in the brain, as well as the serotonin and norepinephrine pathways, which are crucial for regulating mood. So if we're going to take a look at the progression of the pathophysiological changes that occurs in Parkinson's disease, it begins with the neurodegeneration in the brain, specifically the limbic structures. Now, when we speak of the limbic structures, that could include the hypothalamus, which has a role in our emotional response, the basal ganglia, which is responsible for both movement and motivation, as well as the amygdala, which is also responsible for our emotional response. So in essence, the parts of the brain that are affected in Parkinson's disease have specific effects on both mood and movement. So that, as you get to see in the picture that we have here, the image, you see the signs and symptoms of Parkinson's disease: stoop posture, masked face or expressionless face, back rigidity, and the forward tilt of the trunk, so that when the patient moves, it's like a propulsion or propulsive gait. You have the flexed elbows and wrists that usually doesn't swing when they move around, reduced arm swinging, the resting or hand tremors, which may occur unilaterally, meaning it would initially affect one arm, and then eventually it affects both arms, so it becomes bilateral. And then you have tremors in the legs and slightly flexed hip and knees, and of course, shuffling, short, and step gait that increases the risk of the patient for falls. All of this because of the neurodegeneration changes in the brain, specifically the limbic structures. Okay, and then from there, there's going to be a decrease in dopamine, serotonin, and norepinephrine, which would definitely impact the mood of the patient, and that leads to depression. And so depression may initially be one of the earliest manifestations of Parkinson's disease. So that's how it could potentially progress. Although sometimes depression comes after the diagnosis of Parkinson's disease. Now, depression in Parkinson's disease is a part of the disease process itself, which means it is not something that just develops. It is something after the disease or after the initial diagnosis, but it is something that is the after effect of the neurodegeneration in some parts of the brain. So it's also important, therefore, that we need to always screen Parkinson's disease patients from non-motor symptoms like depression, anxiety, sleep problems, and constipation, because they may appear earlier than the motor signs of Parkinson's disease. So speaking of the motor signs of Parkinson's disease, what are these? Now remember our acrostic bad deaths. Once again, this is a copyrighted material. If you want to use it, go ahead, but please do cite where you got it. So the first one, let's talk about the B in the word bad. That's bradykinesia or slowed motor movement. And then A, absence of arm swinging when walking. And then D, drooling. D, difficulty swallowing and speaking, so that increases the risk of the patient for aspiration. And then the client is excessively clumsy, so you see clumsiness in a patient with Parkinson's disease. And eventually they develop bowel and bladder incontinence that could tell us that the patient is in the later stage of the condition. And of course, your pill rolling or resting tremors that initially occurs unilaterally and then it becomes bilateral. And speech abnormalities like slurring. Some patients, because of the depression, may have monotonous speech. Okay, so remember, bad deaths. Now, antidepressants alone may not fully work for depression associated with Parkinson's disease. So which drug is usually given? You have your pramipexole, which is a drug that increases the dopamine levels in the brain. So if a Parkinson's patient presents with depression plus apathy or anhedonia, anhedonia means loss of interest in pleasurable things, including sex or hugging or touching or kissing, your pramipexole may be considered since it addresses both the motor and the mood symptoms of Parkinson's disease by targeting the dopamine pathway. So in essence, a prolonged use of pramipexole eventually would have the potential of increasing your dopamine. But the problem when you have increased dopamine is that the positive symptoms of increased dopamine levels that are associated with schizophrenia may manifest, like delusions, hallucinations, looseness of associations could develop in the patient who's taking this drug. So pramipexole is a dopamine agonist, meaning it stimulates dopamine receptors directly. And I'd like to highlight two important things that you need to remember. First, your pramipexole should not be given with amitriptyline. Amitriptyline is a tricyclic antidepressant, and if it is combined with your pramipexole, the amitriptyline will definitely worsen the sedative effects of pramipexole. Next important thing that you have to remember, if your patient is being given pramipexole, assess the patient for signs and symptoms of increased dopamine levels, and that includes your delusions and hallucinations. So remember the 3S for the side effects of pramipexole: sleep attacks, shopping, sexual or gambling compulsion, so they become hypersexual, or they have like manifestations of a hypermanic state like excessive shopping and excessive gambling, and then eventually they develop swelling or edema. Now, anticholinergic side effects like nausea, vomiting, constipation, orthostatic hypotension may also develop in a patient who's taking pramipexole. So here we go. Case number 48. Patient profile, Mr. Anthony Cruz, 58-year-old male, married, retired accountant 3 years ago. Antonio, as he is called by his wife, presented to his primary care physician with low mood, fatigue, loss of interest in habits, and poor concentration. including a report of sleep disturbances, difficulty initiating activities, and reduced appetite. All of these are manifestations of, you have the diagnosis, major depressive disorder. He was started on selective serotonin reuptake inhibitor. Now let's try to figure things out if this is indeed just major depressive disorder or depression associated with Parkinson's disease. In which case, if it is depression that comes with Parkinson's disease, your SSRI alone would not work. On assessment, the patient manifests masked faces or reduced facial expression, bradykinesia, slowness in initiating movement, cogwheel rigidity in the right upper limb, meaning very rigid muscles, mild resting tremor in the right hand. Now, so the 62-year-old patient, here's a simple question. Parkinson's disease is prescribed pramipexole. The nurse is teaching about the expected effects of this medication. Which of the following symptoms may decrease with pramipexole therapy? Select all that apply. Now, what the question is asking is, which symptoms may decrease? We learned a while back through our functional concepts that your pramipexole would address both the motor and the mood disturbances that comes with depression associated with Parkinson's disease. So definitely, will it address bradykinesia? Yes, that's a motor abnormality associated with Parkinson's disease. Resting tremor? Yes. Muscle rigidity? Once again, yes. Hallucinations? No. Okay. Hallucinations will increase. The question is asking which symptoms may decrease, because as I said a while back, your pramipexole may potentially increase dopamine, and comes with the increase of dopamine would be the symptoms associated with the positive manifestations of schizophrenia that includes delusions and hallucinations. So 4 is not part of the correct answers. And anhedonia, loss of pleasure or motivation, or lack of interest in pleasurable things like touch, okay, cuddling, okay, or even sex. So the answers therefore are 1, 2, 3, and 5, except hallucination. So these are your correct. So let's talk about case number 49, cleft palate and speech rehabilitation. So when we speak of cleft palate, it is something that develops in utero when the tissues of the mouth and the palate fail to fuse during early fetal development. That's approximately during the 6th to the 10th weeks of pregnancy. So this condition is congenital. What could have potentially caused it? Well, there are several factors that increases one's risk, and the most common of which could be genetic factors. So there could be genetic predisposition, or it could be related to maternal smoking, alcohol use, or certain medications. So you have the sad habits again, meaning smoking, S, smoking, A, alcoholism, D, drugs. So if the mom is engaged in any of those 3, there's a greater risk for the baby to have cleft palate. And of course, folate deficiency. Now, a common source of folate during pregnancy is the intake of green leafy vegetables. So you need approximately 300 to 400 micrograms of green leafy vegetables. Now, if you're taking the folic acid supplements, you have to make sure, and this is a functional concept I'd like you to remember if you're taking your test, that you avoid taking your folic acid supplement with tea, because your tea decreases the absorption of folic acid. And then obesity also increases the risk, diabetes, and advanced maternal age. So all of these would interact to potentially affect the development of the soft palate, the hard palate, or both. And this could potentially occur with or without cleft lip. So eventually that results to feeding difficulties because of the presence of the cleft palate that would lead to the inability to create suction. So therefore, it can potentially lead to nasal regurgitation. That can lead to ear infection. So otitis media is a potential complication, hearing loss, and speech difficulties. So in other words, a child with cleft palate could face several challenges like poor nutrition, frequent ear infection, or otitis media that could potentially lead to hearing impairment, speech and language delays, and of course, dental issues. So what is the best intervention for a child with cleft palate? Early multidisciplinary care is essential. That means the child should undergo surgery, palatoplasty, and lip repair if there's cleft lip. And these are typically done between 6 to 18 months of age. So the earlier, the better. And then that's followed by supportive interventions that includes feeding assistance, provision of special nipples, which I'm going to share with you in a while, speech therapy. So you have to refer the parents to the speech therapist. And since the client is at risk for recurrent otitis media, they need audiology tests frequently. And then, of course, dental and orthodontic care and interventions, plus the psychological support they need, because definitely if they get to see themselves different from the other kids, that would definitely impact their self-esteem. Okay, so interventions for cleft palate include, remember, the acrostic cleft. Okay, communication support. So there should be early speech therapy and encourage the client to use clear, slow speech, support language development, and prepare for possible surgery. And then L, latching and feeding assistance. So you need to use special bottles or nipples, the Haberman feeder, which I'm going to show in a little while. Feed the baby in an upright position and burp frequently to prevent aspiration and regurgitation. So frequently burp the baby in between feedings. Then ear and hearing monitoring. Regularly assess the baby for otitis media and hearing loss. Refer for audiology or EENT testing for ear tubes if recurrent infections occur. And then F, family education and support. So the most important aspect of discharge instruction in the care of children with cleft lip or cleft palate should be to teach the parents about how to take care of the surgical site, feeding, surgery schedules, and realistic expectations. In other words, they have to realize that there are certain delays in terms of speech of the child, and then provide psychosocial and emotional support. And lastly, team approach. So refer the client to the multidisciplinary cleft team comprised of the plastic surgeon who will be doing the surgery, speech pathologist for the rehabilitation of the speech of the child, audiologist for the prevention and monitoring of potential ear infections, orthodontist because definitely the cleft palate could affect the growth of the child's teeth. And then, of course, the nurse and the psychologist for the emotional concerns. Now, the referral to the multidisciplinary cleft team will ensure holistic and long-term management. So this is the Haberman feeder, and it has several parts that we need to focus on, like the sleep valve at the tip, okay? And then we have here the markings that indicates the position of the sleep valve in the baby's mouth, which means the longer it is, meaning the raised mark, the greater the flow. So if you want to feed the baby slowly, you have to check on the sleep markings, okay? And of course, this is how it looks overall, okay? That's the Haberman feeder for the child post-cleft palate surgery. Take note that the area that is usually inserted into the baby's mouth is made of silicone, okay? So that's really, really soft. For our case number 49, we have Maria, 29-year-old pregnant woman, is seen at the prenatal clinic. Let's try to identify the risk factors for cleft lip. If we get to see some based on the patient profile. She admits to smoking half a pack of cigarettes, so there's one. Occasionally drinking alcohol, so 2 of the 3 sad habits. So remember, sad habits: smoking, alcoholism, and use of drugs. She has poorly controlled type 2 diabetes. That's another risk factor. Is not compliant with her folic acid supplements. That's 4. The nurse educates Maria that her baby is at risk for certain congenital anomalies, including cleft palate. 6 months later, her baby undergoes cleft palate repair surgery, and after 24 hours, the nurse is caring for the infant. Let's check on the question related to this case. Okay, So which of the following interventions are appropriate for the nurse to implement after 24 hours post-cleft palate surgery? Now, what is essential after cleft palate surgery is to prevent the potential disturbance of the surgical site, and that would entail applying restraints. Now, the elbow restraints is actually applied on the patient's elbow, and there's the more primitive form of it, there's a tongue depressor or a tongue blade in between, so it prevents the patient or the baby from flexing the elbow. So the elbow restraint, therefore, helps prevent the infant from touching the surgical site. Yes, that is correct. Encourage breastfeeding immediately to promote bonding. Well, the breastfeeding is not done immediately, as it could potentially put pressure on the surgical site. So no. Position the infant supine to reduce aspiration risk. No. After cleft palate surgery, it's either you position the baby side lying or prone to promote the drainage of secretions. Provide pain management as prescribed. Yes, that is needed. Avoid placing hard objects like pacifiers or spoons in the mouth. Yes, you need your Haberman feeder. And of course, offer clear liquids using a cup or syringe if ordered. Yes, the cup or the syringe is a necessary tool to help facilitate feed a child 24 hours post-cleft palate surgery. So, therefore, the answers are 1, 4, 5, and 6. And this is how your Logan bow or Logan bar is used after a cleft lip and a cleft palate surgery. So it's applied over the cheeks, and this would decrease tension on the suture line, especially when the baby cries. It can potentially put tension on the suture line, so you need your Logan bar or Logan bow. Okay, case number 50. And before anything else, let me first share with you what this topic is all about. So we'll talk about bronchiolitis, otherwise known as acute viral bronchiolitis, or respiratory syncytial virus bronchiolitis, since RSV is the most common cause. Or it's also sometimes known or called infantile bronchiolitis for the type that would usually affect children under 2 years of age. So on to our case number 50. Once again, we're going to talk about bronchiolitis. So RSV is a common cause of bronchiolitis and pneumonia in children. Now, what usually happens in RSV? So the respiratory syncytial virus infects the epithelial cells lining the small airways or the bronchioles, and this would lead to airway swelling and mucus overproduction by the goblet cells in the airway. So eventually, because of the swelling and the overproduction of mucus, airway obstruction occurs that could potentially result to airway trapping because of the collapse of the alveoli. And so that leads to atelectasis and hypoxemia that results to impaired gas exchange. So your priority nursing diagnosis for a child with RSV should be impaired gas exchange. And if your priority nursing diagnosis is impaired gas exchange, validate your diagnosis by looking at the arterial blood gas results of the patient. Okay, so since RSV involves inflammation of the airway, so what are the common symptoms? You have RSV, so respiratory distress, manifested by fast breathing, wheezing, retractions, and nasal flaring. S, secretions, so you'll see runny nose, cough, mucus plugging that causes congestion. And V, very irritable with feeding difficulty. Now, the irritability could be associated with a decrease in oxygen supply. This irritability could potentially lead to poor feeding, fuzziness, which could potentially lead to dehydration. Now, pay particular attention to the fact that in young children, infection, whether it be viral or bacterial, is initially presented by a specific symptom. That is your poor feeding. So if a child does not really feed the usual way they do, then chances are they could be suffering from infection. Okay? For elderly patients, the initial sign of infection, whether viral or bacterial, could be confusion. That's why it will be asked about the initial sign of pneumonia in young children. It's going to be poor feeding, and for elderly patients, it's going to be confusion. Now, the priority intervention for RSV is to maintain an airway that's patent and to provide oxygen support. So maintain a patent airway by suctioning nasal secretions. Infants are nasal breathers. So if you don't suction their nasal secretions, it would be difficult for them to maintain their oxygen supply. And then provide humidified oxygen if the SpO2 drops below normal. So monitor the oxygen saturation levels of the child. Now, your RSV requires a combination of contact and droplet precautions. That's why if you need to cohort clients with RSV, it's safe to pair only with another RSV case. So for RSV, the best roommate, therefore, is another child with respiratory syncytial virus, and that has to be confirmed by the physician. If no same diagnosis patient is available, the nurse should place the child in a single private room to prevent cross-infection. Never cohort with immunocompromised patients because these patients are at risk for infection, infants without RSV, or those with other respiratory illnesses like pneumonia or asthma. So you cannot cohort a child with RSV with a child with pneumonia because the risk of transmission among patients with pneumonia or asthma is really high. So here's a quick fix tip. Treatment for RSV, since it's a viral type of infection, requires supportive care. When there is severe RSV, ribavirin is usually used for life-threatening RSV cases, especially if you have a child who is immunocompromised. Immunocompromised children, like preterm babies, okay, needs to be given your ribavirin. For the prevention of RSV, palivizumab, a monoclonal antibody, is given monthly during RSV season to high-risk infants, meaning preterm babies, those with congenital heart disease, and those with chronic lung disease. Now, take note, palivizumab is not a treatment. It is used for prevention of RSV. So if it's going to be prevention, then palivizumab. Treatment for severe RSV, then you have your ribavirin. And let's move on now to our next generation NCLEX-RN case number 35. And we're going to talk about Rocky Mountain spotted fever. Now, what should come to mind when you see Rocky Mountain spotted fever? Two things. One, that this is usually manifested by rashes. And two, just like your Lyme disease, this is transmitted to humans through your tick bites. Okay, so before we talk more of that, let me just share with you the good news. A 66-year-old passed the NGN through our system last December 2, 2024. She's the oldest we've got so far, and she broke the record of Jane Sereno, who passed at age 60, and of course, Nanay Pasita Reville, who passed the NGN at age 61, and Ma'am Flor Pangilinan Villarreal passed the NGN at age 66. Okay, now back to Rocky Mountain spotted fever, or RMSF. It is a bacterial disease. It's actually caused by a rickettsia that spread to humans by ticks. So you have your wood ticks, that's your Dermacentor andersoni, American dog ticks, that's your Dermacentor variabilis, and or your brown ticks. So these ticks are the ones that would transmit your Rickettsia bacteria to human beings, and that could potentially develop into your Rocky Mountain spotted fever. So a common sign of Rocky Mountain spotted fever is a rash. But before the rash, there's usually fever for 2 to 5 days. And then the rash appears. Initially, it will be non-itchy. It's flat. And there will be red blotches or pinpoint dots that develops into eventually your bluish or purplish petechial rash with a centripetal pattern on the 6th day. What do we mean by centripetal pattern? It begins on the distal part of the extremities moving towards the center of the body or the trunk. So from the distal part moving towards the center of the body. That's your centripetal pattern of presentation of the rashes in a client with Rocky Mountain spotted fever. Now, pay particular attention to the fact that RMSF is spread through tick bites. So you may want to assess if the client who is manifesting rashes and fever could have gone through areas where they could have been exposed to ticks, wood ticks, or American dog ticks. And that would definitely help in the diagnosis of the client. So there are 3 common manifestations of RMSF, and these are your FRH, Father H, fever, rash, and headache. Now, how do we know that this is Rocky Mountain spotted fever? First, focus on the characteristics of the rash. So to differentiate it from Lyme disease, in Lyme disease you have bullseye rash or rounded rings of rash. Here in RMSF, you have flat rashes that eventually becomes petechial. Now, to compare it in terms of the pattern of the occurrence of the rashes, in clients with measles, they would usually have rashes that begin on the scalp and at the back of the ear, and then it spreads, moving down to the trunk. In German measles, the rashes usually begin on the face and then spreads to the trunk. So those are cephalocaudal in terms of distribution. So from head going down for both measles and German measles. For Lyme disease, it's usually rounded. And for Rocky Mountain spotted fever, centripetal, meaning from the distal part of the body, the arms and the legs, moving towards the trunk. Okay. And then your RMSF also comes with headache. Now, the other manifestations aside from your rash would be muscle pain, stomach pain, and of course, the lack of appetite. Now, remember once again the code RMSF. To summarize the symptoms: rash, muscle pain, stomach pain, fever, headache, and lack of appetite. Sometimes it could lead to vomiting. Now, there's no vaccine for your RMSF, unlike in Lyme disease, where the vaccine was actually eventually it was taken out of the market because of very poor demand, primarily because your Lyme disease can be treated with oral antibiotics. So it's in the mid 2000s. Okay, I think it was 2005 when the vaccine for Lyme disease was withdrawn from the market. For RMSF or your Rocky Mountain spotted fever, there's no vaccine. So RMSF is treated with doxycycline, which is an antibiotic. And like your tetracycline, doxycycline has the potential to stain the teeth. And if you may want to instruct your patient to minimize the staining, they can use special toothpaste that could lighten up the staining once it develops for clients who are taking your doxycycline. Now, what are the common complications of Rocky Mountain spotted fever? We have damage to blood vessels, hearing loss, and mental disability. The most severe among these 3 would be the damage to blood vessels. That could potentially lead to amputation if it's not properly treated. So RMSF, therefore, is potentially fatal. So here we go. Here's case number 35. After a hiking in April, 21-year-old male develops fever. Now, the first sentence alone gives you a lot of clue. Hiking is an outdoor activity. Now, the time from March to August to September is usually the time in which the ticks are active because the temperature would allow them to be a little more mobile. So it's no longer winter. And you have the presenting symptom fever. That simply means there could be an infection that could have developed. And then he was tested for Lyme disease, but the results were negative. So this would tell you that this could not be Lyme's. But let me also highlight the fact that your screening test for Lyme disease is not 100% accurate. And then he soon develops pinpoint rashes that started on his left leg. The nurse should anticipate treatment protocols related to which possible diagnosis. Now remember, in Rocky Mountain spotted fever, the rashes initially present as flat, and then They could appear blotchy and then eventually pinpoint and petechial. So the nurse should anticipate treatment protocols related to which possible diagnosis. Where in measles, usually the distribution of growth would be cephalocaudal, meaning from the head going down to the trunk. The same is true with German measles. The difference is in measles, usually it begins from the hairline or behind the ear to the face down to the trunk. German measles begins from the face down to the trunk. For bacterial meningitis, even if the rashes could be petechial, usually bacterial meningitis also presents with signs of meningeal irritation like nuchal rigidity, your Brudzinski sign and your Kernig sign. And those are not necessarily present in Rocky Mountain spotted fever. So by eliminating the first three diagnoses, namely measles, German measles, and bacterial meningitis, this is a clear case of number 4, Rocky Mountain spotted fever. So join our hundreds of thousands in passers from more than 36 countries where the Gapuz system now is being used and be the next NGN passer. So once again, this is your mentor, your fact check buddy Gapuz at your service. For those who are about to take your test, good luck and God bless. And for those who are still thinking of how they should prepare for NGN, you want to crack it at 85 questions on your first try, join us. See you in our next video. Let's move on now to our next generation NCLEX-RN, case number 34. But before that, let me pose a challenge to everyone. Look at this important topic here. Are you even considering studying hypomagnesemia? If not, then you're in for a big surprise if you're taking the test anytime soon. On to our discussion of hypomagnesemia. Now, it occurs when the serum magnesium concentration is less than 1.8 milligrams per deciliter or less than 0.17 millimoles per liter. Now, there are literatures that say that the normal magnesium level is 1.7 to 2.2 milligrams per deciliter. A 0.1 difference would not harm you. So for as long as you are able to interpret the manifestations of how to spot the condition, then the normal value is not a cause for alarm. Remember in the test, the normal values will be made explicit on your test. So it doesn't require you to memorize your normal values anymore, okay? So hypomagnesemia usually occurs with hypokalemia and hypocalcemia. And these three electrolyte imbalances, hypomagnesemia, hypokalemia, and hypocalcemia, could lead to a condition known as torsado point, which can potentially develop into ventricular fibrillation, the most dangerous type of arrhythmia. So it's very important, therefore, to assess the client's magnesium level. Otherwise, the heart reacts. Okay. So there are certain drugs that may cause hypomagnesemia, and this would include, remember, your CAFP, cisplatin, which is a chemotherapeutic agent, and it's a nephrotoxic agent. Amphotericin B, which is also nephrotoxic, and that's usually given when your clients have fungal infections. Furosemide, which is a loop diuretic, and your proton pump inhibitors like your pantoprazole, omeprazole. Okay, pay particular attention to your prazoles. Now, if your patient has been taking proton pump inhibitors for a long period of time, chances are they've not been able to absorb adequate magnesium, and so they can suffer from hypomagnesemia. Now, high intake of zinc, approximately 142 milligrams of zinc per day, that is too high because the recommended dietary allowance for zinc is just 8 milligrams per day for females and 11 milligrams per day for males. So which gives us the range of 8 to 11 milligrams per day as your recommended dietary allowance for zinc. So the higher intake of zinc you have, the less magnesium absorption occurs, which simply means that you have to regulate your zinc intake if you want to maintain a balance of your magnesium levels. So what are the foods that could potentially increase your zinc intake? First and foremost, your seafoods. Okay, the single highest zinc containing seafood is your oyster. Okay, so seafoods like tuna, sardines, okay, all of these can add on to your zinc intake, which could potentially decrease the absorption of magnesium. Other foods that contain zinc could be your beef, okay, including your dark chocolates. Okay. Now, how would you know that your client is having hypomagnesemia? Now, there are usually neurologic symptoms that includes, remember, your TLH, tremors, lethargy or decreasing level of consciousness, and hyperreflexia. So these three, tremors, lethargy, and hyperreflexia, should raise the red flag on your end that you have to assess the client for hypomagnesemia. Other symptoms, you have your TC now or take care now. You have your Trousseau sign or carpopedal spasm that's usually elicited by using a BP cuff and inflating it 20 millimeters mercury above, okay, the blood pressure, okay, that you have, okay, systolic blood pressure. Now, you can also elicit your Trousseau sign by using a tourniquet. So if there's an obstruction in the circulation of the distal part of your hands, okay, then the digits will become spastic. So that's Trousseau sign. Vostick sign, on the other hand, is facial muscle twitching that is elicited when you percuss the area of the facial nerve, just right in front of the ears, and that could potentially send the facial muscles on that side twitching. Okay, so you would note, or if you're trying to recall, that your Trousseau and Vostick signs, these are also associated with hypocalcemia. So these are manifestations that are not exclusive to hypomagnesemia. Trousseau and Vostick sign are also present in hypocalcemia. And of course, you have your gastrointestinal symptoms like nausea and anorexia plus muscle weakness. That could be secondary to the decrease in the potassium levels of the client. Now, how do we supplement our magnesium? Remember to source it from your food. So remember the code BANDS. So we begin with banana and black beans, and then avocado, nuts, your dark chocolates. And this is what's funny. Dark chocolate contains zinc that could potentially decrease the absorption of magnesium, but at the same time, it's a good source of magnesium. So if it contains both zinc and magnesium, you can go ahead and include it in your diet. So the popular brands of dark chocolate include your Lindt and Godiva. And of course, spinach and seeds like sunflower seeds or flax seeds. These are all very, very good sources of magnesium. Remember the code BANDS: banana and black beans, avocado, nuts, dark chocolates, spinach, and seeds like sunflower and flax seeds. So hypomagnesemia can be treated with either oral, intravenous, or intramuscular administration of magnesium sulfate. That's the treatment of choice. That's the priority treatment. And remember, hypomagnesemia may occur in clients with, remember, HALU, the conditions: hypercalcemia, alcoholism, those who are taking loop diuretics as a form of treatment like furosemide, and of course, when the client is suffering from uncontrolled diabetes mellitus. Remember the code HALU may potentially lead to hypomagnesemia, hypercalcemia, alcoholism, loop diuretics treatment, and uncontrolled diabetes mellitus. So let's now analyze case number 34. A client who is being rehabilitated for alcohol abuse is sent to the emergency department of a hospital due to suspected ventricular fibrillation as reflected on the electrocardiogram results. Here we go. So there are certain part of the first sentence that should give you a clue. First, the client is suffering from alcohol abuse, which could be a risk factor for electrolyte imbalance, specifically hypomagnesemia. The client is suspected of having ventricular fibrillation, and a precursor of ventricular fibrillation could be torsado point, which is primarily associated with low magnesium levels. Okay, so low magnesium levels towards the point could lead to ventricular fibrillation. So that should help you come up with an idea. Medical history reveals treatment for peptic ulcer disease. Treatment with peptic ulcer disease usually would involve your proton pump inhibitors. Remember the prazoles, pantoprazole, omeprazole, okay? And then previous treatment with cisplatin, bingo. That's a chemotherapeutic agent that's nephrotoxic. Whenever the client receives nephrotoxic medications plus loop diuretics, then you can be sure they could be at risk for an electrolyte imbalance like hypomagnesemia. So the nurse should further assess for risk factors associated with which condition. Hyperkalemia, no. Usually what's associated with hypomagnesemia would be hypokalemia. Hypercalcemia, no. It's hypocalcemia. Hyponatremia, no. But definitely the answer is contained in option number 4, hypomagnesemia. So I just hope you learned from our discussion today. So let's move on now to our next generation NCLEX-RN, case number 33, and we're going to talk about, you heard it right, skin cancer. Now, when you talk of skin cancer, two things come to mind. Is it a melanoma, meaning it's something that develops in the pigment manufacturing layer of the skin, that's your melanocytes, which is a more serious form of cancer, and this is usually common in men, specifically on their chest and at their back, and for women, take note, women, it's commonly occurring in the legs. Non-melanoma are those that develops either in the upper layers of the skin, that's your squamous cell carcinoma, or those that develops in the lower or bottom part of the epidermis, and you call that as a term, would usually be related to it, basal cell carcinoma at the base, okay? Or Merkel cells of the skin. Now, Merkel cells are the cells that contain your touch receptors. Now, these are usually influenced by hormones from the endocrine gland. So there's usually a chance that growth could actually occur within this group of cells, okay? Now, your non-melanoma could occur either on the face, the ears, the hands, the shoulders, the upper chest, and the back. Now, pay particular attention to the difference. Let's take a look at which part of the skin layers are affected. So may I draw your attention to your squamous cell carcinoma. As the term implies, squamous cell affects this type of lesion affects your squamous cell, meaning the upper part of the epidermis. And to compare that with your basal cell carcinoma, it just doesn't affect the upper part of the epidermis. It goes all the way to the base. And of course, your melanoma affects not just the epidermis, but the dermis, specifically your melanocytes, okay? So you would notice that your melanoma digs deep into the layers of your skin, okay? Now, the first sign of a melanoma skin cancer is the appearance of any skin changes on an existing spot or mole. Skin changes could be described as itching of a previously non-itchy lesion. It could be described as change in the color, change in the appearance, change in the diameter. And of course, there's an inconsistency in the color of the lesion. Okay. Now, on the other hand, the first sign of the non-melanoma skin cancer could be the appearance of a lump or discolored patch, meaning it's flat and scaly, or skin that persists and progressively develops on the face, ears, back, or chest, okay? So you have a flat and scaly skin that persists and that progressively develops. So it's as if you're having crusted layers of the skin that looks dry, okay? So now, if you're going to take a look at this lesion, what would tell us, what would give us a red flag could be that the color is variegated. It is not consistent all throughout the area. There is an area that's colored black, there's an area that's colored purplish, and there's an area that's colored reddish and pinkish. So this is what we call variegated discoloration, okay? Now, the presence of high density of freckles, high number of moles, pale skin, old age, family history are risk factors for melanoma skin cancer. And those who are usually residing in Australia, because of the nearness of the area of the continent to the equator, they are more exposed to higher density of ultraviolet rays. And so therefore, they are more at risk to skin cancer. So overexposure to ultraviolet light, meaning that includes your artificial sun tanning boots or sun tanning beds or sun lamps, is the main cause of non-melanoma skin cancer. When you speak of non-melanoma skin cancer, that could be your squamous cell carcinoma or basal cell carcinoma. So let's differentiate the two. There are two types of non-melanoma skin cancer. You have your basal cell carcinoma. It's also known as your rodent ulcer, and this approximately accounts for 80% of the cases. And then we have your squamous cell carcinoma, which accounts for approximately 20% of cases. So basal cell carcinoma starts in the cell lining, the bottom of the epidermis. As the term implies, basal cell, it says the base of the epidermis. The squamous cell carcinoma affects the lining at the top of the epidermis. So squamous, top, basal cell, bottom part of the epidermis. Okay, so in terms of appearance, your basal cell carcinoma appears shiny pink or pearly white. It could be red, scaly patch with brown or black pigment within the patch, and this is painless. However, the ulcer can bleed. For squamous cell carcinoma, it could appear as firm and pink lump with rough or crusted surface and the spiky horn. Now, the ulcer also bleeds easily. So if an ulceration in the skin bleeds, then it could either be basal cell carcinoma or squamous cell carcinoma. How do you differentiate the two? Pay particular attention to the color. Although both could start as pinkish, eventually you have a variation in basal cell carcinoma when it becomes pearly white, okay? And it progresses to brownish or black pigment. And of course, your squamous cell carcinoma, pay particular attention to the fact that it could appear crusty or spiky, meaning it's a little rough. Okay, so if it's pearly white, that's basal cell carcinoma. Crusty or spiky, that could be squamous cell carcinoma. Now, how do we assess for early signs of melanoma? Now, the characteristics are usually summarized in the mnemonic or acrostic ABCDE, meaning there's a symmetry. So it simply means that the area that is affected by the tumor are imbalanced, meaning to say there's a part that's smaller, there's a part that's larger. So that's a symmetry. Now, it's usually irregular, so which means the borders are not defined, and within the lesion, you have different colors. You have variegated discoloration. And of course, the diameter is greater than 6 millimeters or 0.24 inches. How do you operationalize that? It's about the size of a pencil eraser, meaning it's larger than the size of a pencil eraser. And this is the most significant thing that the client should be told about. That if the lesion evolved over time, meaning from a small lesion, it enlarged, then that could be a red flag. Now, there are other classifications, however, that apply to the most dangerous form of melanoma, and this is known as your nodular melanoma, which has its own classification, not the ABCDE thing, but you have EFG, elevated above the skin surface. So if you try to assess it, you try to feel through the lesion, then it's firm to touch and it's growing. Okay, so this is how it looks. Let's compare a benign from a malignant skin lesion. So notice that there's a symmetry in a malignant lesion. One side is different from the other. Compare that with a benign lesion, it's usually encapsulated. Then the border is irregular in a malignant lesion, and usually it's very defined in a benign lesion. The color is mixed or variegated. Look at this lesion, it has different colors from different parts, whereas in a benign lesion, the color is more or less consistent within the lesion. The diameter is larger than 6 millimeters for the malignant lesion. Compare that to the smaller diameter of the benign lesion. And of course, the mole evolves over time. From a small mole, it has now become enlarged and it has become variegated in color. And of course, the border becomes irregular. So that should raise a red flag when you're assessing your moles. Now, Bowen's disease is a precancerous form of squamous cell carcinoma characterized as red scaly patch on the skin that may itch. Definitely, if a mole itches, it is something that you need to pay particular attention to, and you need to refer that immediately to your healthcare provider. Now, let's differentiate the three. Squamous cell carcinoma typically presents as a firm red nodule or scaly crusted sore. Remember, squamous, scaly crusted sore. Basal cell carcinoma often appears as a pearly, translucent bump with visible blood vessels, and melanoma usually manifests as dark, irregularly shaped mole or growth with uneven coloring. Once again, it is crusted, scaly, squamous cell carcinoma. Pearly, translucent bump, basal cell carcinoma. Dark, irregularly shaped, melanoma. So let's answer case number 33. A 52-year-old lady from Australia, that should be a red flag. Knowing you have a middle-aged lady here, common in females, take note, from Australia who is having a vacation in New York, comes for consultation due to a bleeding scaly crusted sore on her left leg. That should give you a clue. Bleeding could occur in either basal cell carcinoma or squamous cell carcinoma. However, you have here a description that says scaly and crusted on her left leg. We mentioned that your skin lesions in ladies could usually appear on their legs, So she reveals that the growth has been there for a while. She lives near the beach. That's also a red flag in her country, and admits to having her tan maintained through tanning boots, another red flag, or sunbathing. The nurse should further assess for risk factors associated with which condition. Is it melanoma, basal cell carcinoma, squamous cell carcinoma, or Mongolian spots? Definitely, your Mongolian spots is not common among Caucasians. Your Mongolian spots is actually common among dark-skinned babies, usually those of Hispanic, Latino, Native American Indians, Africans, and Asians. They usually have a purplish discoloration in the lower part of their back that usually fades at 5 years of age, or some people could have it until adult years. But your Mongolian spot is something that is not a cause for alarm. So hence, we have to focus on options 1, 2, and 3. Well, when you say melanoma, we remember dark colored. We don't have that in the situation. So we're left with 2 or 3. Basal cell carcinoma, remember, it's supposed to be pearly. We don't have that in our case. And the single most important description that you have to focus your eyes on could be the words scaly, crusted, sore on her legs. These are most likely indicative of it's not melanoma, it's not basal cell carcinoma, it's not Mongolian spots, it's squamous cell carcinoma. Let's move on. Okay, so now let's move on to case number 31, and we're going to talk about anaphylaxis. In layman's term, this could be associated with an allergic reaction. And let's begin CS. Here we go. So let's now talk about anaphylaxis, and let's begin with a functional concept. Remember, a functional concept is a word, a phrase, a sentence, or even an entire paragraph that gives you a sense of direction on how you would deconstruct a question. In essence, it's the chewable version of your concept specifically designed for the NCLEX-RN. So anaphylaxis is a life-threatening, acute, rapidly evolving allergen-driven process involving immunoglobulin E. So pay particular attention to the fact that immunoglobulin E is associated with anaphylaxis. okay? And anaphylaxis occurs within 2 minutes to 2 hours of exposure to a trigger. A trigger could be insects, okay? It could be bees or your wasp or your cockroaches. It could even be associated with the change in weather or the food that we take, or sometimes even exposure to trees like juniper trees and even fruits. Okay, so it's very important for us to note these things when we are talking of anaphylaxis. Let's move on. So anaphylaxis is the most severe form of hypersensitivity that can lead to shock. So it's very important for us to note the client's airway and then note if there's going to be a changes in the vital signs, specifically a drop in the blood pressure with compensatory increase in the cardiac rate. So anaphylaxis is manifested, remember, rash, okay? So respiratory system symptoms like difficulty of breathing or shortness of breath, or the client could describe it as chest tightness. So that's an important thing to note. Next, abdominal pain. So the patient may experience this in the beginning phase of the anaphylactic reaction. And then skin rashes and hives. Although hives in either acute or chronic form, this is not life-threatening. However, the resulting edema in the airways related to hives can make breathing difficult. And that's what needs to be addressed in an emergency manner. And definitely headache. So remember, rash, respiratory symptoms, abdominal pain, skin rashes and hives, and headache. Whenever you see this group of symptoms, think about a possible anaphylaxis reaction. And among patients who have these symptoms, prioritize a client who is suffering from hives because they could develop edema of the airways that could definitely restrict their breathing, leading to decreased oxygenation. Now, anaphylaxis requires emergency interventions because it occurs within 2 minutes to 2 hours. Remember the rule of 2. So therefore, it is very, very important that we manage anaphylaxis fast, okay? And that's our acrostic for the management of anaphylaxis, beginning with putting the client in a flat position. Don't allow them to walk, don't allow them to move. So immediately put them in a flat position. That's a preventive intervention just in case their blood pressure immediately drops. And then adrenaline injection like EpiPen should be administered to counter the reaction caused by the elevation of your immunoglobulin E. And then you need to start an IV antihistamine and cortisone for the prevention and treatment of the inflammatory processes that could result from anaphylaxis. And finally, you need to immediately transfer the client to a hospital, and that would require at least a 4-hour stay in the emergency department for proper monitoring. Remember, treat anaphylaxis fast. Flat position, adrenaline injection through your EpiPen, start IV antihistamine and cortisone, and transfer to a hospital. Now, before we apply what we just have learned, let me just share with you the good things that they're saying about my book, NCLEX-RN 311, the Next Generation Quick Fix Edition. And this is coming from one of our friends who use it, and her pseudonym is I am Pilia. Meron din po na lumabas sa akin, saka po blank, kaya nakangiti po ako na sumasagot kasi nabasa ko siya sa NCLEX 311. She's talking about at least 2 cases that came out in her test, and she found that in our book. Now, on to our case study number 31. Let's go through it. Let's apply what we just learned. So a client comes to the emergency department for difficulty of breathing and rashes. And whenever you see those 2, anaphylaxis should immediately come to your mind. After a walk in a public park to enjoy the springtime weather, she has a history of latex allergy and asthma. There you go. You have our risk factors. So after the stroll, she had the dragon fruit shake and a banana strawberry float at an old park restaurant where some cockroaches were seen. So the client's condition is not related to which one of the following. The key word here that I'd like to highlight is the word not. So let's get through this. So difficulty of breathing and rashes brings to mind a potential anaphylaxis. And what are the triggers? Well, The change in weather could be 1, because usually in springtime, the weather could be around 10 to 15 degrees centigrade. So she has a history of latex allergy and asthma. Okay, those are 2 things that are also associated with immunoglobulin E. After the stroll, she had a dragon fruit shake and a banana strawberry float, where this is actually where the difficulty is, because you have to relate whether dragon fruit shake could be triggering the latex allergy or the asthma, or could it be the banana strawberry float? That's the main argument. And of course, we have here cockroaches. Now, we talked about this early on, and we said that insects, and including bees and cockroaches, including dust mites, could actually trigger your anaphylaxis. So the client's condition is not related to which one of the following. Let's go through the options. The weather, definitely a change in weather is a trigger for asthma. So that's not the answer. The cockroaches, it's a trigger for allergic reaction. So that's not the answer. We're left with 2 or 3. The fruit shake or the float drink. Now, remember that latex allergy is usually associated with fruits such as avocado, banana, kiwi, strawberry, and clients with allergies to kiwi can be at risk for another form of allergy, and that is dragon fruit allergy. So dragon fruit is not directly associated with latex allergy. So therefore, the answer to this question would be the fruit shake. I just hope you like the challenge posed by this case. So here are our pointers, set number 48. Now, the first question that you have to ask yourself when you're preparing for the next generation NCLEX is, what are the things that I need to study? And you need to get an expert opinion for you to be able to have a clear overview of what you need to focus on. That's the keyword, focus. Okay? So, in this set of pointers, allow me to highlight one important concept, and that is vaginitis. Vaginitis is actually a general label for conditions that could lead to inflammation of the vagina. And there are things that you have to remember about this. So whenever you think of vagination, think about the 4 common complaints of clients with this condition. It could be painful urination or painful sex. So this does not just happen once. Okay, this could actually persist. Vaginal bleeding, itching, and vaginal discharge. That should give you the clue. When there's itching and vaginal discharge, think about an infection. And the next important thing that you have to remember is, what type of discharge is the patient having? Is it grayish white and fishy in smell, thick white and cheesy in characteristics, or is it greenish yellow and throaty in its appearance? Therefore, each of these types of discharges corresponds to a specific causative agent. Like, for example, a grayish white fishy discharge could mean there's bacterial infection. The thick white cheesy discharge could mean there's a yeast infection or yeast growth. And if there's greenish yellow throaty discharge, that could mean there's going to be a condition that could be related to the presence of a parasite or a protozoa. So when the discharge is grayish white and it smells fishy, think about bacterial vaginosis. That is the most common vaginal infection among females. And take note, if there's thick white and cheesy discharge, think about a yeast infection, moniliasis or candidiasis, the second most common vaginal infection. Among, definitely, Americans. And of course, when there's greenish yellow flow to discharge, think about parasitic or protozoal infection, and that could be associated with trichomoniasis. So when it's grayish, vaginosis. When it's cheesy and white, moniliasis or candidiasis. When it's greenish, trichomoniasis. Now, if your patient is having any of these manifestations, it's important that you perform thorough assessment. Okay, and if we speak of thorough assessment, what do we need to focus on? Okay, we need to focus on the risk factors that they could be having, because based on this, a diagnosis is arrived at and the specific treatment can actually be identified. So, for patients with bacterial vaginosis, it's usually treated with clindamycin. Of course, that's an antibiotic, or your metronidazole. Now, there are certain things that we have to remember related to clindamycin. First and foremost, it could cause your DVI, diarrhea, vomiting, and itching. And take note, it's both hepatotoxic and nephrotoxic. So if the client could be having persistent anorexia, think about hepatotoxicity. If the patient's having decreased urine output, think about acute kidney injury. So your clindamycin is usually to be taken by the client twice a day, 300 milligrams for each dose, and that's usually taken for 7 days. And then, of course, you have your metronidazole. Your metronidazole would usually cause darkened urine. So instruct the client that that's not a cause for alarm. And you will have to instruct the client to avoid sex for at least a week if they have taken your metronidazole, and they have to avoid alcohol within 24 hours after taking the medication, because that could potentially worsen the hepatotoxic effects of the drug. And for moniliasis, take note, it's usually treated with echinocandin that's given per IV. That's an antifungal medication. The common side effect would be flushing and rashes. And it's also hepatotoxic. So note for the loss of appetite, yellowing of the sclera, and of course of the skin. Now, amphotericin is also antifungal. The most common side effect is diarrhea. Take note that it can potentially become nephrotoxic. So it's best to administer it in diluted form with 5% dextrose in water, and it's administered intravenously over a 2 to 6 hour period. Now, we have to remember that we need to flush the IV tubing with D5 water before and after administering the medication. And of course, for trichomoniasis, okay, it is also treated with metronidazole. For trichomoniasis, metronidazole is the first line of treatment. Usually, it's given as a single dose orally, and the client is given 2 grams. Or it's given in 4 white pills form, and each pill contains 500 milligrams. If the patient is taking the 500 milligrams pills, instruct the client to take all 4 pills at the same time and take the full glass of water, and definitely instruct the client to avoid alcohol in the next 24 hours, and most importantly, avoid sexual intercourse for at least a week to make sure that the medication has already exerted its therapeutic effects and the condition has already been treated when the patient resumes any sexual activity. Okay, so when signs of vaginitis occur, what do we need to ask the client? We need to ask the client if they are doing, using, or has any of the following. 1, we need to ask them if they are douching, if they have uncontrolled diabetes mellitus, if they already have menopause, because after menopause, there's usually an imbalance in the hormones that increases the risk for vaginitis. We ask them if they are pregnant, or if they are fond of wearing tight-fitting or damp clothes, because these tight-fitting and damp clothes could usually is a good culture medium for bacterial growth. And if they are using a toilet paper properly. So they have to wipe the perineal area from front to back, making sure that no fecal matter is delivered into the vaginal area. And of course, if they are using tampons, because this could increase the risk for vaginitis. We also need to assess if they are taking oral pills, or they are using intrauterine device, or if they are sexually active or have had history of sexually transmitted infection, or if they are taking steroids and antibiotics. All of these are risk factors to vaginitis. Now, what are the things that we need to instruct our clients to avoid when they have vaginitis? We instruct them to avoid our code BUDS, which simply means it's an acronym for bathtubs, bubble or whirlpool baths, having multiple sexual partners, that should be avoided, definitely. Underwear worn to bed, so it's better if they don't wear their underwear at night, so that the perineal area could at least be exposed to air. And then avoid douching, that could further push your microorganisms into the vaginal canal. And avoid soap with deodorant or antibacterial action. So instruct the client to avoid Lifebuoy antibacterial soap, and instead use your Dove or Castile unscented soaps. So it would be best if they use the unscented soap, so they don't suffer from irritation of the vaginal mucosa. So to prevent vaginitis, the client should wear pantyhose with cotton crotch. They can wear pantyhose, however, the crotch area should be lined with cotton. That facilitates absorption of moist, that would definitely lessen the incidence of vaginitis. Let's move on to our pointers number 47. And the first thing that you have to consider when you're preparing for the next generation NCLEX is to ask yourself, what do I need to study? But be sure that when you get the information on what you need to study, you're getting it from people who have been through the process, which means they are certified and they passed the NCLEX-RN, because there's a whole lot of false prophets out there teaching NGN, and yet they have yet to pass the NCLEX. How can a blind lead another blind? So be very careful and ask if your mentor is a passer of the NCLEX-RN. So let's begin with my first pick for this set of concepts. And my first pick would definitely be, Crohn's disease. Okay. Now, Crohn's disease is an inflammatory bowel condition that affects your small and large intestines. Although if you're going to take a look at the picture below, it could appear at any point in your gastrointestinal tract, from your mouth to the anus. So which simply means it could be anywhere. And there are two things that you have to remember about the pathophysiology of Crohn's disease. It involves, one, inflammation, okay? And two, it could be triggered by an autoimmune reaction. So what are the common risk factors? There's a genetic basis to the disease, and smokers are 3 times more at risk to develop Crohn's disease. So how do you know that a client has Crohn's disease? So first and foremost, you have an inflammation. So there's going to be fever. And then because of hypermotility related to the inflammatory process in the GIT, your patient would more likely have diarrhea. And the diarrhea could be bloody and mucoid. And sometimes it contains fats. And because of that diarrhea, there's going to be weight loss. And take note, this is Crohn's disease. The pain is usually in the right lower quadrant of the abdomen. Now, what are the complications that we expect? So number one, there could be bowel obstruction, as well as your Crohn's disease is a risk factor to cancer. So The condition can be treated with, remember, CAM. The first line of treatment would be your corticosteroids, and that's followed by your adalimumab, which is given subcutaneously. Your adalimumab would help block the inflammatory process. Your azathioprine would also do the same. And of course, your methotrexate, which can help maintain remission of the disease. So simply put, your Crohn's disease is a condition that is treatable. And your outcome parameter should be evaluation of the decrease in the signs and symptoms if your client is indeed in a period of remission, which means the signs and symptoms are absent. That's your remission. Okay, so when the signs and symptoms reappear again, that's called exacerbation. Okay, so let's move on. Now, my second pick for this session would be your thromboangiitis obliterans or your Buerger's disease. Now, this is also known as your Winnie-Water Buerger's disease. Take note, there are two things also that I'd like you to remember about your thromboangiitis obliterans. One, it's a condition characterized by inflammation, and two, thrombosis or clot formation of the arteries and veins, primarily of the feet and of course the hands. So it affects the toes, the feet, the fingers, and the hands. Okay, so remember thromboangiitis obliterans. This is more common among males, but it also can affect females. And the main symptom is pain in the affected areas, okay? Pain that occurs at rest, and it's worsened by walking. So this is sometimes referred to as intermittent claudication. Now, if you'll be asked on the test, how do you assess for intermittent claudication? You just have to ask the client to walk until they feel some pain, and then you ask them to take 1 to 2 minutes of rest and then reevaluate. If the pain disappears with the rest, then that's positive for intermittent claudication. Now, pay particular attention also to the fact that your thromboangiitis obliterans could be associated with impaired circulation due to exposure to colds. And the peripheral pulses could be absent or diminished, and then the extremities would usually change in color, ranging from bluish, that means there's cyanosis, to reddish blue. And the most important thing, take note, eventually the skin becomes shiny and hair growth is reduced. The reduced growth in hair could be associated with impaired arterial circulation. Okay? So the priority intervention here would be providing information to the client to stop or quit smoking. Now, there are 3 important goals that you have to remember for clients with thromboangiitis obliterans. One is to decrease pain, and that is usually done through the administration of iloprost. Okay, that's given usually intravenously. Now, the purpose is to relieve the pain and to promote healing of leg ulcers that could result from the impaired circulation. The second would be to prevent clot formation. So, fibrinolytics or thrombolytics like your streptokinase could actually help in preventing the formation of new clots, and it also helps dissolve the existing clots. And of course, last but not the least, is to decrease inflammation. Although some have questioned the effects of corticosteroids, it cannot be denied that eventually, in terms of facilitating recovery, your corticosteroids could also help a client with thromboangiitis obliterans to recover. Okay, so, and my third pick for this set of pointers would be your Aprepitant, okay, that could be given orally or intravenously. Now, Aprepitant is given as a medication for nausea and vomiting that's related to chemotherapy. However, the use has already been proven effective to address nausea and vomiting that usually occurs post-operatively. Okay, now there's another version of the drug, that's your fosaprepitant. So remember the suffix prepitant, okay, like the cetrons on dansetron, okay, that's used to relieve nausea and vomiting. Now, what's the difference between aprepitant and fosaprepitant? Your aprepitant could be given either orally or intravenously, whereas your fosaprepitant is only given IV. Now, for the side effects, remember the code CHAND, C-H-A-N-D. Okay, C can potentially cause constipation. H, remember this for your test, H, hiccups. And then A, anorexia. And then N, nausea. And then D, diarrhea. So remember, your aprepitant can cause both constipation and diarrhea. Remember CHAN. Once again, constipation, hiccups, anorexia, nausea, and diarrhea. Okay? So this is usually given to clients with nausea and vomiting associated with chemotherapy, as well as post-operative nausea and vomiting. Okay? So the second thing that you have to consider when you're preparing for NGN is the use of technology. Some of those learners we've coached for the test would know the answer in their mind, but the moment they use the mouse to point the cursor to the areas that they would want to click on, sometimes their fingers would slip. So what they're saying is it takes mastery of both content and technology to pass NGN. And we'd like you to develop the strategies for those two areas, content and navigating technology. Here we go, our pointers, set number 45. So the first question that you need to ask yourself when preparing for the NGN is, what are the things that I need to master? And it's not just browsing notes or skimming your notes. It's about concept mastery. And you need an expert opinion to enable you to focus on those things that matter the most. Don't waste your time. Be under the wings of someone with a heart and with the patience and with the brain to guide you. We're here at the Ray Gapuz Mentors to do that simply for you, because we believe you can turn your dreams to reality. So let's begin with the first concept. So hiatal hernia. Now, looking at the picture, what happens in hiatal hernia is that a portion of the stomachs would usually slide upward into the chest through an opening in the diaphragm. So it's called hiatus. That's why when a part of the stomach, the upper part, slides upwards through the hiatus, and we term it hiatal hernia. Okay, so what causes hiatal hernia? Remember the risk factors. Remember the code CLOP, CLOP. The first one is actually chronic coughing. Then L, you have lifting heavy objects. So this is common among weightlifters. O, I'm guilty, obesity. And P, persistent straining or vomiting. How would you know that you have hiatal hernia? Note for the BAD symptoms. So BAD is actually an acronym, BAD. First one, belching or heartburn. Then A, acid reflux. And then D, difficulty swallowing. So what are the things that we can do if we have yet to have surgery to correct hiatal hernia? First and foremost, we begin with how we eat. So we need to eat small meals 3 to 4 times a day, which simply means that we have to have small, frequent meals. And it's very important for us, okay, to remain upright at least 3 to 4 hours after meals before we lie down or lay down. Now, pay particular attention to the fact that we also need to limit fatty foods, because fat delays emptying of the stomach, and so therefore it increases the chance for us to have acid reflux if our stomach contents are stored for a longer period of time because of too much fat. Okay, we also need to avoid acidic foods, and of course, those that contain caffeine and alcohol. And since this is associated with obesity, we need to lose weight, to stop smoking, and in order for us to manage the symptoms properly, we can ask our doctors to consider prescribing antihistamines or antacids for the control of the symptoms. Okay? So how will you know that these treatment regimens or conservative interventions are working? Definitely when you have less episodes of belching or less episodes of heartburn. Okay? Now, the next important thing that I'd like to share with everyone is actually the complications post-thyroidectomy. And this is important because one of the concepts that's being covered in the test is reduction of risk potential, which simply means that the nurse to be able to identify factors that could potentially trigger a worsening of the client's condition. And this could mean that we always have to be on the lookout on the development of complications. Okay, so the two most common complications post-thyroidectomy, the first one, we have your hypocalcemia. Now remember that the normal calcium level is 9 to 10.5 milligrams per deciliter. So hypocalcemia occurs when the calcium is less than 8 milligrams per deciliter. And the condition is corrected through the administration of calcium. And of course, to facilitate the absorption of calcium, we need your vitamin D. Now, why do we need to correct the hypocalcemia? Because if the hypocalcemia is not corrected, it could potentially lead to laryngospasm that will make it difficult for the patient to breathe. Okay? So that's the first one. The second most common complication of thyroidectomy would be your injury to the recurrent laryngeal nerve manifested by hoarseness or dysphonia, in which case when there's hoarseness, there's damage to the vagus nerve. Okay? So this can potentially lead to a life-threatening dyspnea. So in essence, it would make it difficult for the patient to breathe. So it's very important also that we need to assess the ability of the client to speak after, or if there's a change in the quality of the voice. So we could very well conclude that the patient could be having injury to the recurrent laryngeal nerve. Next, bleeding. This could be associated with, of course, the surgical intervention. So the priority is to facilitate evacuation of the hematoma. And how do you assess for bleeding? Slip your hands at the back of the client's neck or the nape area. Why? Because of the principle of gravity, blood usually oozes and flows towards the back. So even if the dressing is dry and intact in front, it's going to be at the back or behind the neck, in which you will have some dampness. And the most important thing that you should never ever forget is to monitor the client's vital signs after thyroidectomy for two reasons. One, if the blood pressure goes down and the pulse rate goes up, then suspect that the client could be having bleeding. But what happens if it's the temperature that goes up coupled with an increase in the pulse rate? So you have fever and tachycardia, then that's when we can say that the client is developing thyroid storm or thyroid crisis, which could lead to atrial fibrillation and then eventually congestive heart failure. Therefore, thyroid storm is a medical emergency, and it's initially treated with a beta blocker like your propranolol to lessen the activity of the autonomic nervous system responsible for the fever and the tachycardia. And of course, that's followed by the administration of your antithyroid drugs, including your propylthyrosol or PTU, and of course your methimazole, or the administration of iodine solution. Now remember, the prevention of these complications begin even before the surgery is performed. Let's talk about pyloric stenosis. So let's focus on the picture that we have here. So the pyloric sphincter is found between the stomach and the small intestines. When the pylorus, the muscles between the stomach and the small intestines gets thickened or it enlarges, then we have a condition known as pyloric stenosis. Now, the exact cause is not known, but this definitely runs in families. So it's 4 times more common in boys. And if one male baby had this, the siblings are 30 times at risk to develop the same. So which simply means that if a mother whose baby was diagnosed to be having pyloric stenosis asked the nurse, what is the chance of their next children of having the disease? Then you can honestly say the next children will also be at risk for developing pyloric stenosis. Okay? And then there are studies that support the findings that pyloric stenosis develops in pregnant women who use antibiotics, specifically erythromycin, during pregnancy, or if their neonates were given erythromycin because they suffered from upper respiratory tract infection, including whooping cough during the neonatal period. Now, the presence of hernia could also increase the risk for having pyloric stenosis, as well as the sad habits or smoking and use of drugs by the mother, specifically your antibiotics. Okay, how would you know that your child has pyloric stenosis? The outstanding manifestation would be projectile vomiting. When we say projectile vomiting, it's a vomiting that's very forceful. In fact, the vomitus could reach a point of 4 to 5 feet from where the baby is. So you can just imagine that's a very forceful discharge of vomitus. And because of this projectile vomiting, the baby becomes very hungry all the time, and eventually they get dehydrated. And since they are dehydrated, they also get constipated. So the intervention for these types of children with pyloric stenosis is to correct the dehydration, give them formula every 3 to 4 hours. Usually they can be fed within 4 to 6 hours after surgical intervention. Now, there's one drug that's used for the treatment of the projectile vomiting, and this could be given orally or through IV. That's your atropine sulfate. So how would you know that atropine sulfate is effective in a child with pyloric stenosis? That's when the projectile vomiting decreases. Okay. So the next question that we should be asking ourselves is, how do we study for the test? We need to study with technology. You have to learn how to navigate those questions that are on to our next generation NCLEX-RN pointer set number 43. So the first thing that I'd like to share with you today is actually about hypovolemic shock. So this is a life-threatening condition, and therefore it is a medical emergency. So the main problem here is a very severe blood or fluid loss, and this makes the heart unable to pump enough or adequate amount of blood to supply the body's needs. So when you say hypovolemic shock, this could very well be related to bleeding or burns, or a patient could be having severe diarrhea or even pancreatitis. Now, how do we know that the client is developing hypovolemic shock? It's primarily through the monitoring of vital signs. So you will notice that there will be very low blood pressure and increased heart rate. So if you note those two, then you could very well think of hypovolemic shock. So remember, there's gonna be low blood pressure and then high pulse rate. And definitely there's gonna be low temperature and high respiratory rate. So remember, pay particular attention to the fact that your client could be having hypotension, tachycardia, tachypnea, and definitely low temperature. So the priority intervention should be to place the client on a position in which you will be able to facilitate the distribution of blood and fluids into the body. And so that would mean that you have to place the client on a position in which the body should be flat and the lower extremities could be slightly elevated. Now, the priority intervention after putting the patient in the right position is to administer crystalloid fluids, or pay particular attention to this fact, colloid fluids are less likely to be used. Why? Because this could potentially induce allergic reaction and blood clotting disorders, as well as kidney failure. So the most important thing that you have to remember is you need to prepare your isotonic crystalloid solutions. And take note, you don't give the client with hypovolemic shock your antihypertensives or vasodilators. This would definitely worsen the client's condition. So for patients with dehydration, but they have adequate circulatory volume, your hypotonic solutions are used. This could be either 5% dextrose solution or 0.45% saline solution. So pay particular attention to these things. Remember, for hypovolemic shock, position and fluids would be the key. Okay, now let's move on to the second NCLEX-RN alert concept that I'd like to highlight. This is your Nortriptyline. The brand name is actually Aventil or Pamilor. Now, this drug is a tricyclic antidepressant. Now, pay particular attention to the fact that your antidepressants are not rapid acting. So initially, the therapeutic effects could come in after 2 to 3 weeks, and the full therapeutic effects could actually be evident after 3 to 4 weeks. So if the patient is just taking the drug for at least a week and they're saying that they're not feeling any difference at all you have to do is to reinforce to the client that they may need to wait a little bit more, because it takes time for the drug to exert its therapeutic effects. And how would you know that the drug is indeed exerting therapeutic effects? 2 things to consider. One would be you have to check the client's appetite. So if they're asking for additional snacks, that simply means that the medication is now exerting its therapeutic effects. And second would be improved sleep. Now, caution though that if they are sleeping at daytime or they're having like 10 to 12 hours of sleep, that could be indicative of hypersomnia. The normal duration of sleep should only be 7 to 8 hours. Okay, so off-label usage of your Nortriptyline would be, it is used to decrease neuropathic pain, especially if your patient could be having herpes zoster, or if they are having other types of neuropathic pain induced by other conditions. And of course, it could also be used to facilitate or treat the client in order for them to quit smoking. Now, when your patient's taking Nortriptyline, it's very important that you assess whether they're taking other types of antidepressants, especially for those who are taking herbal antidepressants. Now, tell them that they should not combine St. John's wort, that's an herbal antidepressant, with your Nortriptyline. Or if they're also taking medications for migraine headaches, like sumatriptan, frovatriptan, elatriptan, they should not also be combining these medications with Nortriptyline, as the adverse effects could actually be more severe. Okay, now when is the best time to take your antidepressant? So ideally, in order to decrease drowsiness, so the antidepressant must be taken an hour before bedtime, or in order to improve its effectiveness, it could be given with vitamin B6 in order for the medication for its therapeutic effects to be improved. Now, what about if you are given a choice of which food or food groups could be high in vitamin B6? Now, pay particular attention to the fact that your vitamin B6 rich foods could also be your protein rich foods. So it's all right to administer the medication with adequate amounts of protein. Now, what are the important things that you have to tell your patient before they are to take Nortriptyline? First, assess if your patient has glaucoma. Why? Nortriptyline can potentially worsen increased intraocular pressure because it causes pupillary dilatation. So it's not given to clients with glaucoma. And of course, if your client has type 1 or type 2 diabetes, your Nortriptyline could also potentially alter the sugar levels. It's also very important to note that your tricyclic antidepressants can potentially trigger palpitation. So it's important that you check the client's ECG tracing for any abnormal heart rhythms before you administer the medication. So once again, take note, Nortriptyline.